Good morning and welcome to today's Congressional webinar on Alzheimer's disparities and the public health response. My name is Stephanie Monroe. I am Director of Diversity, Equity, and Access and Inclusion of Us Against Alzheimer's. I'm also a 25-year veteran of Capitol Hill, and most importantly, the caregiver for my father, who has been living with Alzheimer's disease for close to 10 years. Alzheimer's is the disease of the century. With over 6.5 million people diagnosed with Alzheimer's and related dementias, and 17 million unpaid caregivers of those individuals, it is the most costly and feared disease in America. After going to 3 doctors before receiving an accurate diagnosis, my family experienced what too many individuals diagnosed with AD receive: the diagnosis, a prescription, and the door. No support, caregiver planning, or next steps. This cannot continue. That's why public health system approaches are so important. Today, we're going to start the webinar with an introduction to the disease by listening to a caregiver from a patient perspective. It's great for us to understand the numbers and the impacts, but nothing is better than for us to hear actually from people who themselves have experienced. So I'd like to turn the conversation now over to Martha Villanegro Santiago. Martha?
Thank you, Stephanie. And here is my mother and myself a few years back, pre-pandemic. Good morning. My name is Martha Villanegro Santiago, and I am here to share my Alzheimer's journey on behalf of my mother and other family caregivers who have become family care providers. I quickly learned that Latinos must tackle the lack of accessible dementia information and resources. Every day, I feel the urgency for improvements to the healthcare system. My mother's journey, similar to Stephanie, began with my mother's longtime primary care doctor. When she gave us the diagnosis, she turned to my mother and asked, "You know what Alzheimer's is, right?" To which my mother said, "Yes." I am an attorney, but nothing had prepared me to care for my mother with this terrible diagnosis. I did not know the ways that Alzheimer's would impact her daily life, furthermore, change mine. At the time, my mother had been living independently and alone in New York City. My mother had always been a strong, independent, and working woman. My sister and I had left New York City many, many years ago. However, we regularly kept in touch and spent holidays with her. However, as a Latino family, spending family time was part of normal life. After learning my mother's diagnosis, I understood the piles of unopened mail in her house, the unopened pill box, many of them opened in her potted plants, the spoiled food in the refrigerator, and the many, many department store bags hidden in the closet with the tags on the clothes. She had always been adamant of never leaving New York City, but one night in a local ER, with tears in her eyes, she looked at me and said, "Please take me back to Virginia." After seeing the signs of my mother's unhealthy routines, my sister and I made the difficult decision to take my mother to a nursing home in Virginia. We were confident that my mother could no longer live by herself and needed supervision to take her medication. We disregarded the common belief amongst many, many Latino families that only family could provide the best care. In the past 9 years, my mother has become more dependent on professional staff for daily needs. Mother does not understand English, and as her primary caregiver, I supervise and track that care that she receives. I don't want her to feel alone. A family caregiver's life is non-stop, whether the care recipient lives with the caregiver or whether the person living with the Alzheimer's lives in a nursing home. My mother receives the care, but as her primary caregiver, I'm continually making the medically related decisions on her behalf. I regularly visit the nursing home. I speak to doctors, I speak to staff, I ask for consultations with the medical professionals. I ask for medications, I request tests, and I track that medication and supervise that care and request the outside medical appointments. But the most distressing call is that emergency call when my mother is fallen or is having another episode of confusion and agitation, which has been happening frequently this past year. I must act quickly, however, the dilemma for me is taking the best action. In 2013, I had no choice but to resign from my nearly 30-year career in law. Unfortunately, many family care providers must rely on themselves for finding answers. I identified many sources, including the UsAgainstAlzheimer's, the Alzheimer's Association, for information and support. The alarming reality is that a knowledgeable and healthy caregiver is critical for Latinos to get the care and the access to information they need. In these 9 years, we have repeatedly confronted the same barriers. Some of those barriers include few, if any, medical professionals that are culturally diverse. The fact is, they don't need to speak a foreign language. Body language works. For my mother, often smiles work. As a consequence, patients can't get appropriate care. Another barrier is that the doctors do not develop relationships with their patients. They merely ask, do you need another refill for your medication? And a consequence of that is that doctors can't possibly accurately diagnose or give the proper treatment. Thirdly, medical and health professionals do not know or understand the symptoms of Alzheimer's and dementia. As a consequence of that, like my mother, other Latinos fail to get the help and the information they need. Lastly, the treatment and ongoing care provided to dementia patients excludes caregivers. As a consequence, a healthcare provider is ignoring vital information that only the caregiver can provide based on daily care and knows about any changes in behavior. In closing, none of us should forget the awful truth that Alzheimer's, there is no cure. As the number of older adult Latinos grows, so does the probability that Latinos will also be diagnosed with dementia and Alzheimer's. Government healthcare systems can no longer postpone developments in improving dementia care for all communities. I thank you to give me this opportunity to share my Latino family's journey in caring for my mother living with Alzheimer's. Now, I introduce Dr. McGuire.
Thank you very much for the opportunity to speak today. Next slide, please. So today I'm going to share with you some of the public health approaches to Alzheimer's disease and related dementia and how we are utilizing those at CDC. Next slide, please. So what is that public health approach? As you can see from this graphic, with the public health approach, we are trying to approach the health of the population with a group of individuals at a time, as opposed to a one approach. We're trying to make sure that our treatments, our interventions, our assistance is touching and assisting as many people at a time as it possibly can to achieve the strongest and the greatest impact. Next slide, please. This slide shows us the bridge and shows us one of the key functions of public health. So public health here is that middle piece. We are the convener, we are the connector. And what public health does is it connects and it bridges that biomedical research and the community services. So for example, the National Institute on Aging conducts amazing biomedical research with their findings that occur at the left side of this bridge. On the right side, the Administration for Community Living provides amazing services for people with ADRD, as well as services through the Older Americans Act. But we need that middle part. We need to be able to take that scientific knowledge and to translate it and to make sure that it is actionable and can be implemented within those community services on the right-hand side so that we can work on improving risk reduction, detection of Alzheimer's and dementias, diagnosis, as well as the management of it. The next slide. The next slide is my mom. This is Dora. Dora has also really a mixed dementia, and I am one of her primary caregivers. This is Dora in December of 2019, so right before the pandemic. She was very happy. We had just had a wonderful family Christmas dinner. But I like to also show her face too, to talk about, very much like Martha did, each of these individuals that we're talking about, these are people that someone loves, someone cares about, part of their family system and part of their family structure. So the point that I want to make on the slide with Mom, since she's helping me out today, is that public health really does have a role in the field of Alzheimer's disease and related dementias. And when we look with that public health approach that we can see here on the left-hand side, there are multiple points of intervention from a public health perspective across not only the life course of a person's life, but also the process of the disease process too. So we can look at primary prevention. We can look at doing things that can help reduce your risk of Alzheimer's disease and related dementias. If you're a caregiver from a primary prevention perspective, we can look at ways to make sure that you're taking care of your health, getting your vaccinations, seeing doctors about your health conditions and concerns. Secondary prevention, this is the early detection and management of Alzheimer's disease and related dementias. And the same thing with the caregiver, making sure that the caregiver is taking care of their health and reaching out to providers when they're having concerns about their health. Tertiary prevention covers a variety of different types of things for somebody who's already diagnosed. This can be the care and service or assistance that a caregiver may provide to the person with ADRD, but it also can be those linkages between care and services and support to make sure that the whole system is as healthy for as long as possible and maintains and is able to maintain their independence for as long as possible. The last thing I want to say about tertiary prevention is, Martha pointed out how stressful it can be to get one of those calls when mom has fallen. I got one of those calls this morning as well too. But one of the things that we can talk about with that tertiary prevention is management of other comorbidities and also the physical environment so that we might minimize some of those calls that we're getting. So for example, if somebody has diabetes, making sure that their diabetes is properly managed and that doesn't lead to potentially a fall, a broken hip, an emergency room visit, surgery, etc. So in other words, that's really an important focus that we see from the public health perspective. Next slide. So CDC has two national initiatives that I'm going to get to in just a second. And these initiatives are for national level, as well as states, local, and tribal levels that really make a collaborative impact to enhance that health, well-being, and independence for people with Alzheimer's disease and dementias and their caregivers. The next slide, please. The next slide illustrates the Healthy Brain Initiative, or HBI as we refer to it lovingly. But the Healthy Brain Initiative really is the goal of that Healthy Brain Initiative was to integrate brain health within the public health system or the public health infrastructure at a national level. Next slide, please. CDC is comprised, as we saw from the previous slide, of Component A and Component B awardees. The Component A awardees developed the Healthy Brain Initiative Roadmap series that we see listed here. And the thing about this Healthy Brain Initiative Roadmap series is what we do is it's about an 18-month process where we look at the science, we look at what type of activities and actions have occurred within the past 5 years within public health. And through this roadmap series, we establish national priorities for state and local public health. And also the document on the bottom right-hand side, we also have a roadmap for Indian country as well. Now, this roadmap series establishes those priorities. Those priorities are consistent with 4 of the 10 essential services of public health that you see illustrated in the wheel in the top right-hand corner. So development of that Healthy Brain Initiative Roadmap series is really one of the largest activities that our Component A awardees do. Our Component B awardees are looking at the populations that have the highest prevalence of Alzheimer's disease and related dementias. And today you'll hear from Us Against Alzheimer's and the amazing work that they are doing with their Component B awards. Next slide, please. And this slide just highlights the awardees and what they're doing and who has received the additional awards. Next slide, please. So BOLD, building our largest dementia infrastructure, is designed to create a strong public health infrastructure across the US that's consistent. And BOLD consists of 3 components that you can see listed on this graphic. The first one of these components is to fund public health departments and public health centers of excellence. So first, public health centers of excellence, departments of public health, and really to look at building the data infrastructure by making sure that data is available quickly, it's easily understandable, and it's really used for action. And these components really also support CDC's director's recently announced priorities to share scientific findings and data faster and also to strengthen that public health infrastructure. The next slide shows us the CDC BOLD Centers of Excellence. So I want to point out that these are national centers of excellence on dementia caregiving, dementia risk reduction, and early detection of dementia. These centers of excellence are a resource for everyone. They are a resource for the nation. So if you're working on dementia caregiving or you're interested in working on risk reduction, please reach out and we'll make sure and get you connected to those principal investigators. Because as I said before, they're not just a resource to public health, they are also a resource to the nation. Next slide, please. So through that second component of BOLD, CDC is supporting 23 BOLD public health centers in states, political subdivisions of states, tribes, and tribal organizations. And today we're going to hear from one of those amazing BOLD programs a little bit later in the presentation. Next slide. CDC takes a collaborative and coordinated public health approach to reduce or delay the risk of cognitive decline in dementia, with an emphasis on improving the quality of life for those with dementia, and especially the quality of life for those who are providing care. Next slide, please. So this slide illustrates, and you'll need to click it a couple times, this slide illustrates how the CDC awardees intersect for a very strategic and coordinated approach to improve that health, well-being, and independence of persons who live with Alzheimer's disease and also their caregivers. Next slide. Thank you very much. And I'm going to turn it over to Stephanie.
Thank you. Next slide. So the Us Against Alzheimer's Center for Brain Health Equity, which is one of the recipients that Dr. McGuire just described, has been working for years to address certain disparities that have appeared in specifically African-American and Latino populations. We have been peeling back the onion, that is the challenges, the series of challenges that face these important populations. and the gaps that have occurred as a result of those issues that haven't been addressed. So we've honed in on 3 particular priorities that we'll be utilizing and addressing through the Brain Health Center at Us Against Alzheimer's. First is we'll be addressing the issue of the lack of culturally tailored and culturally respectful brain health messaging and resources in hard to hit communities. You know, we know that we can have the best information, but if it's not accessible to people, if it's not in their languages, if it's not appropriate, if it's not at a certain reading level, people won't be able to take action on the excellent information that both the CDC and NIA are able to provide. And so we are working to develop a messaging guide and toolkit that can be used in different communities by community partners, as well as public health systems in those particular states. Secondly, we're working to educate and mobilize minority serving health providers. One of the first things that people do once they've accepted the fact that what they're seeing in their loved ones is not a normal part of aging, is to see a health provider. And so health providers need to have the tools and the techniques and the ability to communicate and respond in a holistic manner to people who are coming in who have different cultural expectations, who have maybe received disinformation or misinformation about Alzheimer's. So we need to make sure that they are trained and well equipped. One of the ways that we've done that is to form a nurse fellowship, which currently we have 12 nurses that we are working with in key communities across the country. One of their top priorities will be to educate at least 25 of their peers, and so forth and so on. Nurses are some of the most trusted providers, so we're working specifically with them, but also all of the materials that we are making available to providers, including a brain health academy that we have launched, which is a free service to educate individuals and minority and majority health service providers. Is something that we've also made available for people, and they're able to receive some credit for participating in those different strategies sessions. And finally, we're working to empower community partners and policymakers with data on brain health inequities. Many of you may have received well, sorry, not at this point, but you may have received information about what's happening in your communities, specifically about Alzheimer's disease. We'll talk a little bit later about a data system, a GIS system that we put together that's able to examine health disparities and give us a visual of where people who have these health disparities, where people who are diagnosed with Alzheimer's disease and are able to cross populate that information according to their race, their gender, their ethnicity, and things of that nature, to actually see where they are down to a zip code level. That allows us, as well as community partners, as well as larger entities, to target people in certain communities that we know have a higher prevalence of Alzheimer's disease, and to have a better understanding of why that is. Why is it that certain communities, certain zip codes, we're able to fairly accurately predict that they're going to have a larger prevalence of Alzheimer's disease because of the social determinants that are also happening. We'll discuss that a little bit later as well. Next slide. So why is it important for us to focus on African Americans and Latinos in particular? These are the 2 populations that we know have the highest prevalence of Alzheimer's disease. We know that Blacks are at least twice as likely, and Latinos are at least 1.5 times as likely to have Alzheimer's as non-Hispanic white Americans. We also know that they are less likely to receive a diagnosis at all. In fact, we know that at least 40% of people are not receiving a diagnosis, even though the physician believes they have Alzheimer's disease. They're less likely to have a timely diagnosis. An early diagnosis is absolutely essential to allow the medicines that we have that are symptomatic medicines to be able to have the greatest likelihood of impact on individuals who have Alzheimer's and related dementias. They're also more likely to report experiencing racial discrimination. Almost half of Black Americans and 1 in 3 Latinos reported they've experienced healthcare discrimination. And in fact, other surveys have showed that providers actually are aware of certain biases that they have. And many are working to correct this, but this is obviously a public health challenge in terms of perception and how we are treating patients who we see and who have these cognitive impairments. And then they're also very much excluded from cutting edge Alzheimer's and brain health research. This is a huge problem. Latinos and Black Americans make up less than 10% of all clinical trials that are trying to find cures for Alzheimer's. One of our founders, former Surgeon General of the United States, Dr. David Satcher, has said that up to 40% of Alzheimer's could be prevented if we engage in certain strategies, including getting people involved in research so we can make sure that the treatments and the cures actually work for everyone. As we all know, cure is going to be a lot cheaper than care, which is impacting people in a generational wealth. Let's go on to the next slide. The projected growth and prevalence of Alzheimer's disease is really astronomical. This slide shows where we're expected to be in just, in 2050 from now. It's going to be a huge growth. As you can see, these lines are, extremely steep in terms of the growth of both African Americans and Latinos as those populations grow, and as we have more and more people who are aging while those populations are actually growing. Next slide. The Centers for Disease Control has stated that and are examining social determinants of health, which are the conditions in which people are born, live, learn, work, and play. We've been examining these different conditions, which include, of course, access to health care, access to neurologists, diagnostic machines like PET scans, things of that nature, the environment, the lived environment, opportunities for people to exercise in a clean environment, access to good education, et cetera, all impact whether or not people are going to be more likely or less likely to develop Alzheimer's disease and related issues. Next slide, please. Latinos and Blacks are also more likely, and here's a chart that shows you where they are in terms of being more likely to have a language other than English that's spoken at home, less than a high school education, being food insecure, have parents that are reporting that their children live in unsafe neighborhoods. These all impact the health and the well-being of individuals, which we are seeing correlations between this as social determinants and the likelihood that individuals will later develop Alzheimer's disease. Next slide. UsAgainstAlzheimer's has created a national Alzheimer's disease index, which is a public health tool that aggregates Medicare fee-for-service data and allows us, as described earlier, to actually see where people are living. As you can see on this slide, the red zone is really where there's the highest prevalence of people who are living with Alzheimer's disease. And again, this is a tool that allows us to search down to a zip code level and see where these high prevalence hotspots exist. We issued a report with the Urban Institute that helped us identify the top 25 counties that were most impacted by Alzheimer's disease, and also the bottom 25. And we were able to do a comparison of what was the same and what was different in these two county areas. Next slide. So we've been working, we've had this grant from the CDC we're entering into our third year. The first 2 years, we have accomplished a lot. We did do a briefing previously identifying the 41 counties that I just described as having the top and the bottom prevalence rates. We do have that the data brief that's available, and Daphne just put that in the chat if you want to find more about that. But we did a congressional briefing where we identified those areas so that members of Congress could actually be more aware of what's happening in their background in their own back neighborhood. We've been able to post and access over 1.7 million individuals, sharing with them new information about Alzheimer's disease, about these health disparities, and about things that they can do, using tailored, culturally sensitive and reputational data and information that could be easily understood by people, both in terms of strategies, prevention strategies, treatment opportunities, and clinical trials participation. And that's been very well received nationally. We were able to leverage an additional $9 million in brain health equity investments that have been catalyzed by our center's research. At least 27 public health departments in the U.S. have been reached with center programming in its inaugural year, including one that we'll be hearing about next in Mississippi. And of course, we launched our 12 Fellows Brain Health Fellowship, which we described earlier. Next slide. And so as we enter our third year for 23, we're beginning to plan what we hope to do there. We're planning to launch a second cohort of the Brain Health Equity Nurse Fellowship of at least 12 and potentially more brain health fellows who will be reaching their communities and having community conversations in their areas of reach. And this is a very exciting program. One of our nurses was just featured in the Boston Globe, and we're very proud of all of them. They are extremely enthusiastic, are holding some of their sessions we're going to be holding for at least 200 people in each of these communities or more individually. So we hope to reach, hundreds, if not thousands of people as a result of this work that we're doing in 22 and then also in 23. We've also, we're hoping to launch an additional digital communications campaign. In our first year, we described we had about 700 people that we were able to reach, 700,000 people, I'm sorry, that we were able to reach with these important messages. Second year, 1.7 million, and we're hoping to exceed that in year 23. And also nationally, we hope to disseminate evidence-based, culturally tailored messages and toolkits throughout the country with industry partners and others who are seeking to influence and raise the awareness of the importance of getting early diagnosis. We have found in these two communities in particular, again, a lot of disinformation, misinformation, a lot of beliefs that brain changes are a normal part of aging, or it's an issue that just can't be addressed, or it's an issue that they have so much stigma, they're afraid that they'll be fired if people find out. So they're not seeking diagnosis and help that's available. And so we believe that through these different strategies of being able to target and reach these communities in particular, that we hope to raise awareness so that people will be driven to get the treatments and the cure, and caregivers receiving some of the support that they really need as well. Next slide. And so now I'm pleased to introduce Kina White from Mississippi. Kina.
Sure. Good morning, and thank you so much, Dr. Monroe, for the introduction. On behalf of the Mississippi State Department of Health, I just want to share, next slide, I just want to share how we have been able to work with a number of key stakeholders and partners to address health disparities in Mississippi related to Alzheimer's disease. Next slide. So Mississippi, being the state that it is, we are very unique and we're very resilient. But one thing I wanted to set a context for was our environmental structure. Out of our 82 counties, we have greater than a 16% population of older adults, 65 and older. And the predominance of our state is rural. So we have unique challenges that we face given the prevalence of rural communities in Mississippi. So there is an ever-pressing need for us to continuously address those social determinants of health as we look at reducing and eliminating health disparities. When you think about the rural context, you often see a correlation to higher poverty rates, a lower educational level, and also greater difficulties accessing care. So we think often that the disparity elimination is a part of what we need to do every day and not a special project that we only address at the time of specific funding. Next slide. So these are the headlines. Mississippi is often in the news for one reason or another. And we think about our competing priorities on a daily basis and being able to emphasize our need to be resilient. Mississippi is a very resilient state, whether we're identified as one of the least or one of the first for whatever particular reason the outcomes may show. As of recent, many of you probably have heard about the water crises in Mississippi, in Jackson. And so I live 10 minutes from Jackson, Mississippi. And so these are often priorities that we have to juggle, but we understand the need to address these social determinants of health, because without this mission of really changing health outcomes, we would continue to have emerging disparities. Next slide. So what is public health and what is our approach? In public health, we really want to look upstream. We want to look at those micro level factors to start addressing policy and really look at how we can improve our community conditions. For often too long, we stay in the downstream side where we look at individual care. And I believe a comment was made that it's more expensive to cure than it is to care. And so, well, it's more expensive to care than it is to cure. And so what we often see is that if you look on the right side of this presentation, you have to look at those social determinants. Health behaviors only make up a small percentage. You have to look at clinical care, but those social and economic factors are very real. And how we really educate individuals, how we support them, and how we provide resources to them definitely matters as it relates to those longer health outcomes. And in Mississippi, we have many disparities. We have many inequities. And so we have to balance where those priorities lie. And as we address Alzheimer's and related dementias, it remains the same. Any chronic condition we have, we still have to look at these environmental factors, these social factors, and really look at the upstream approach to addressing care. Next slide. So the BOLT program, Mississippi was one of the inaugural recipients of the BOLT program in 2020. We were a core grantee, which means that we had to establish infrastructure for this work. It did not mean that we had not began some of the work, but the BOLT program provided a specific focus on public health being center stage to address Alzheimer's disease and related dementias. We use the HBI roadmap series that Dr. McGuire mentioned as a blueprint to our efforts, looking at risk reduction, early detection, looking at preventable hospitalizations, care planning, and also supporting our caregivers. Specific to our efforts, we give great attention to health disparities, again, sharing that we're a very rural state, so we pay close attention to the rural disparities, and also looking at our high burden populations. And later in my presentation, I'll describe specific strategic actions that we utilize to implement our BOLT program. Next slide. So these are a few facts and figures just to give a little context. Immediately to the right, if you look at the workforce chart, in the state of Mississippi in 2021, we only had 23 geriatricians to service 82 counties in Mississippi. And if that doesn't raise any alarm bells, I think it should. We clearly do not have the number of geriatricians needed for the total population across our state. In Mississippi, we had the second highest mortality rate in America in 2019 for Alzheimer's disease. If you look at our caregiving statistics, a number of caregivers that are providing day-to-day work, and if you heard Martha share, it's challenging, and many of them have to leave their employment to provide this care. And so in Mississippi, as I shared, we have unique challenges to address as it relates to our disparities in dementias for this crippling disease. Next slide. So how do we do it? Once we received the BOLT program, initially we thought we'd start with our own coalition and we would just begin to say public health will be center stage. But what we've learned is there are so many dedicated to this work that we forged a wonderful partnership with some key partners. The University of Mississippi Medical Center's Mind Center, our State Alzheimer's Association chapter, our Department of Mental Health, and also our Department of Human Services. All of these key stakeholders now serve as this executive steering committee to address Alzheimer's disease and related dementias for our state plan. This was not by mistake. This was a very intentional opportunity to leverage these resources and bring public health to the table with the commitment that we will look at early detection, risk reduction, and provide data that illustrates our social determinants of health impacting individuals in Mississippi with Alzheimer's disease and related dementias. Next slide. But we needed help. Our collaborative impact in Mississippi is strongly based on the foundation provided by CDC, and we are so grateful for the funding opportunity through the BOLD program. We work closely with our centers of excellence. In the University of Minnesota with the dementia caregiving, they have a best practice caregiving compendium that we use at our caregiver conferences. We also utilize this as we train our AAAs to share with them opportunities for training and resources for caregivers. We've worked closely with Us Against Alzheimer's. The NADEX data map that you see to the bottom right of the slide is an actual slide for Mississippi as we were looking at our prevalence in preparation for our pilot of dementia-friendly communities. In Mississippi, we currently do not have any designated dementia-friendly communities, and we wanted to understand at a local social context level, what are those disparities for our hardest hit populations. And so we collaborated with Us Against Alzheimer's to understand what counties we needed to prioritize. And from that prioritization, we worked very closely to establish an infrastructure to begin the development of dementia-friendly communities in tandem with our age-friendly communities. We also have the Brain Health Academy that we share with our health professionals in Mississippi. It's an integrated part of anyone that does the work that we do as a part of our state plan. And we definitely look at shifting from the individual approach to the system level approach for our work. The BOLD funding is phenomenal, but it may not last forever. And so we've begun the preparations to sustain a lot of our works with our stakeholders here in case there is an opportunity where federal funding is not available and we need to continue having Alzheimer's disease addressed from a public health approach as a key priority. Next slide. So here are some tangible examples of how we've been able to look at a policy systems and environmental change approach and embed health equity. With our state plan, we have 5 committees. We have the Brain Health Committee, Community Awareness, Coordinated Care, Research Alliance, and Caregiver Support. So for each of those 5 committees, we have identified one volunteer who is trained and serves as the health equity ambassador. Through the BOLD program, we provide training for them on cultural competency, implicit biases, action planning, so that they have internal knowledge of what we're expecting when we have our efforts out within the communities. We make sure that we empower them with timely information that's provided by Us Against Alzheimer's and many of our other stakeholders, so they understand when they're representing our efforts that they're empowered to speak up if someone is presenting information that may not be culturally sensitive, that they should consider rephrasing how we share this information. Even today, we discuss language and the importance of properly speaking to someone and pronunciation of name as something to be culturally sensitive. We also have a social determinants of health analysis project that we have collaborated with the Mind Center at our medical center. This project is looking at a multitude of literature sources for Mississippi-related individuals diagnosed or being cared for with Alzheimer's disease and related dementias. And the importance of this project is it actually has set a foundational perspective of those social determinants specific to our community and what needs we have: economic stability, affordable housing, some of these key challenges in Mississippi that we face, and that access to care given our limited workforce availability. And we're using this project to spearhead so many different intervention strategies at the primary level so that we can begin to really make an impact on those health disparities. Another project that we have is our Purple Sundays. We collaborate with our Alzheimer's Association state chapter to host Purple Sundays for our faith communities and provide the 10 warning signs and really educate our faith communities on this work. Through our COVID response, we have learned that our faith-based community is such a jewel in this effort to really educate and maintain that village approach. And as we move to a sustainable model, we have now began exploration with Dr. Epps with Georgia State University to look at the Alter Dementia program, because it provides more of a systems level approach to working with faith-based communities, because we want to make sure, again, that this is not a one-stop, that we continue to build these relationships and sustain these communications with our faith community. Next slide. Here are a few additional PSC strategies that we use to address disparities through our Alzheimer's and dementia work. We host an annual inequity symposium where we bring together caregivers, we bring together policy advocates, we bring together our researchers to really talk about national inequities and also local-based inequities and how we want to continually address that work. Data analysis and dissemination is a key part of our BOLD initiative. We work closely with our BRFSS state coordinator, the Behavioral Risk Factor Surveillance System Coordinator. We look at the subjective cognitive decline module and the caregiver module to better understand disparities at our state level of surveillance. And we use those findings to educate our stakeholders so that we can really tailor our state plan initiatives and priorities. For the first time in Mississippi, we hosted a continuing medical education event through our BOLD program, and we were able to discuss risk reduction, early diagnoses, lifestyle management integration within care planning. We talked about the cognitive care planning and billing considerations, and we are so excited to share that through the Division of Geriatrics, they have to this point been the only department utilizing the cognitive care planning tool. However, immediately following our education event, we had our internal medicine office request a copy of the EPIC template and want to be trained to begin using it. That is a huge win for workforce productivity. A couple of other priorities, we've developed an interactive caregiver map that will soon be launched for caregivers on a website. So they will have access to care tools, they will have referral opportunities and directories to better understand resources available in our state. Through our medical center, we do have a 6-week multi-topic caregiver university where caregivers can receive training and better understand their needs. And through the BOLD work, we identify and refer individuals to the caregiver university for that support. We are also working to integrate brain health into our chronic disease programs to address health inequities and disparities. And we also utilize the National Association of Chronic Disease, the NACDD RAC cards that were developed for this work with CDC. So we talk about brain health and cardiovascular health, brain health and diabetes, brain health and physical activity to reduce obesity. Obesity is a significant chronic condition in Mississippi. And so we understand that we have to look at these comorbidities and also looking at those avoidable hospitalizations. If we address some of these other comorbidities, we understand that will have a significant impact on Alzheimer's disease. And then lastly, we're also looking at our age and dementia-friendly communities. Mississippi is also in the early stages of developing an age-friendly public health system. So we're leveraging our resources and working in parallel with our age-friendly communities to establish dementia-friendly communities. So we understand that, again, it is about addressing those social determinants of health and moving forward. Next slide. So next steps, we are going to be launching educational awareness campaigns, and some of those campaigns will include material from the Brain Health Messaging Guide. We're also looking at Know Where Alzheimer's Hide campaign through the association. Again, we're looking for those sustainability approaches and having that collaborative impact, and also identifying an engagement of diverse stakeholders and making sure that representation is present, including myself as a diverse leader in doing this work. And I always say that the goal is to be complementary and never competitive. There's enough space for everyone, and now public health is at the table. Next slide. Thank you so much for the opportunity, and I'll turn it back over to Stephanie.
Well, thank you. I'm really was just amazed at hearing so much that's happening in Mississippi, even with all of the infrastructure challenges that they have. I think this is just a great demonstration of how much our public health workers throughout the country and systems are committed to doing the right thing, despite facing, real challenges that they are. We can always do more. We can always do better. I think we're learning that, and these opportunities here are presenting us with the opportunity to reach communities that really need strong messages, strong connectivity, training at so many different levels. We have a lot to do in this space. We've got to peel back this onion if we really want to stem the tide. In fact, the epidemic of Alzheimer's disease as we continue to brown and grow as a country. We're now going to open up to questions. If anyone has any, I'm going to turn it over to my colleague, the project manager for the Center for Brain Health Equity at Us Against Alzheimer's, Daphne Delgado.
Thanks, Stephanie. Please remember if you have any questions to put them into the Q&A function so that we can look at them, but I will just ask 1 or 2 questions to get started. Specifically for Dr. White, Dr. White, can you describe a little bit more of what a dementia-friendly community looks like for people who aren't as familiar with that term?
Sure. Excuse me. So Mississippi currently does not have any designated dementia-friendly communities. And what it really looks at is the built environment, being able to work with your employers, your grocery stores, those community partners, and being able to have those dementia-friendly resources. If it's enlarged signage, if it's having someone that's culturally sensitive to understanding the irritants of someone with dementia. So if they are in a grocery store and they seem slightly irritated or bothered, that someone is trained to understand how to communicate with that individual. If caregivers have needs and they present to a library or another space, that there's resources available. So dementia friendly is not a term we have coined, of course, and I believe Mary Eck is on the call today who can speak to that with US Aging. And so there's so many toolkits that are available to support this work. And Mississippi is in the infancy stage of beginning to understand how best our built environment can be adapted to support the development of dementia friendly communities.
Thank you, Dr. White. Dr. McGuire, what is CDC doing? Excuse me. What is CDC doing to support or create more culturally appropriate, culturally tailored messages around Alzheimer's and aging?
Thank you so much for that question, Daphne. I think I know in listening to Dr. White's and Ms. Monroe's presentations, they illustrated why it's so extremely important to have culturally tailored messages. So through our Healthy Brain Initiative Component B awardees, we made awards to organizations that work with African-American adults, Hispanic, Latino adults, American Indian, Alaskan Native adults, and also one organization that works with adults with intellectual and developmental disabilities because of the really high prevalence of Alzheimer's disease and related dementias within that population. So, you know, we at CDC are really good at taking, from back to my bridge, taking those scientific messages and translating them into what we think is plain language and usable. But we really need to work with getting those messages to be culturally appropriate, and also to work with communities that have access. So for example, Dr. White mentioned the faith organizations in Mississippi and how it's really integral to get the messages included there. So it's not just tailoring the messages so the health literacy is appropriate, the message is still scientifically appropriate, and it's really accessible, but it's also getting those messages in the hands or in the ears of the people that we want those messages to resonate with. So at CDC, we're trying really hard to do that, as well as translating many of our materials into other languages as well too. And, you know, really, we're at the tip of the iceberg. So we look forward to hearing more from you all of what kind of materials are needed and what kind of materials would be really useful to you in your work. So thank you.
Thank you, Dr. McGuire. Martha, you know, thank you so much for opening the presentation with your very personal caregiver story. You know, you had to quit your job as a 30-year lawyer to take care of your mother full time. And unfortunately, your story is not unique. So given your experience and given what you've seen so far in this 9-year-plus journey with your mother, how could the public health system or the healthcare system change to better support patients like your mom, but also to better support the people who are doing the caregiving and the coordinating like you?
Well, thank you, Daphne, for the question, because we can't state a problem without some possible solutions. And in this journey, with all those challenges that we've confronted, I find that basically, and as Dr. White confirmed in her area, is that the lack of geriatricians and gerontologists, because they often use these two terms, but the doctors, primary care, all kinds of doctors, but the primary care doctors need to be incentivized, that the healthcare systems provide incentives and implement those incentives so that they could go and get this education, regardless of what kind of specialty you have, and that they too learn about how to tell a patient about what is dementia. This is what you will be experiencing, so that the person is not lost. I saw a video yesterday and the person was totally thinking that, holding their head and thinking, oh my God, I'm going crazy. No one had to say it to her. She thought herself that she was going crazy. At the same time, we have to think about what kinds of incentives, and this goes along with getting the education, is that the doctors and maybe other health professionals, other healthcare professionals, whether it be a therapist, could be a physical therapist, it could be a mental therapist, that they spend enough time with the patient to tell them a little bit about, well, you know, you're experiencing the symptoms and what to do about it, or this is what this means. You know, we need to provide those incentives in a healthcare system, because the time is not getting spent, whether it be with a patient or for the professional themselves to get an education, which go hand in hand. And we can't leave out other programs in this healthcare system that provides funding so that these caregivers who've given up a lot and do so willingly, willingly, in the best interest of a loved one, that they get support and throughout the process. So they need to be included from day one of the diagnosis and throughout, and that they be given a check-in and how are you doing today? Well, a lot of times I'm simply ignored in a visit, whether I'm there or not, which is kind of hard to ignore me. But if I don't want to ask questions, but not everyone's going to ask questions. So that medical professional has to know to check in, but perhaps getting that incentive. Did I check off? Okay, I spent time with the caregiver, I checked off, and then I can submit my billing to the healthcare system. So thank you, Stephanie, Daphne.
Thank you, Martha. Lisa, you raised your hand.
Yeah, I was just going to build on what Martha was saying about the primary care providers. And I think when we think of the healthcare system, as Martha was alluding to, we need to think of it as broadly as possible. So we need to be thinking about physician's assistants. We need to think about nurse practitioners. We need to think about community health workers. We need to think about all the different players within the healthcare system that patients might express concerns. They may not feel comfortable expressing them to a physician, an MD, but they may have more interaction and feel more comfortable with some of the other folks that they may interact with as well. So we really need to make sure that our healthcare system is dementia prepared for what it may encounter. And then the last thing I want to say before I see Stephanie's hand up is Kina put in the chat about the National Association of Chronic Disease Directors RAC cards. And she put in a key thing that I forgot to say. They are customizable. So in other words, the information, you can put your logo on it. You can swap out pictures. They are customizable and free for use.
Yes, I wanted to piggyback Dr. McGuire on that. We actually customized the RAC cards in Mississippi. We translated them for English and Spanish because we do have a Hispanic task force that responds for COVID, and we were able to disseminate those to our Hispanic task force. But also I wanted to share in Mississippi, as well as some other states, the collaboration with community health workers and really looking at lay individuals who can have a significant impact on addressing Alzheimer's disease and related dementias. The village community is very appropriate to addressing this work from a public health approach. And because we have so limited number of geriatricians and others, we have to think of other ways to have trusted individuals at the forefront of this work. And so Dr. McGuire, I agree, looking at other professionals and non-professionals who just have the passion to do this work, I think is going to be very important.
Thank you, Dr. White. Stephanie, I know you raised your hand in these last 2 minutes. Maybe you can also close it out.
Absolutely. Well, you know, I think some of what we have learned, number one, is it's wonderful that we often think about prevention of these diseases. And a lot of times the United States is a little bit, slow to focus on prevention. So I'm so pleased that the CDC has prevention in their name. We are understanding much better that there are things that people can do that can certainly mitigate their risk for developing Alzheimer's disease. Many of these are things that are completely doable and accessible to people, including, nutrition and hydration and exercise. Again, reading, brain health exercises, things of this nature. Our Brain Health Academy does feature toolkits and suggestions for what individuals as well as medical professionals can do to make sure that's shared information. We often don't hear it. And I think we all know that from a personal level, that's just not really been a focus of healthcare providers. So encouraging that will be really important for us to address these diseases. I know that we have, this is a congressional briefing, and I'm going to be shamelessly plugging for additional and continued support of these bold programs. They're really important. We could certainly expand what we're doing with them. We'd love to double or triple our nurse fellowship program. There's so many things I know that all the other centers that are engaged in this work would love to be able to engage in, because to address this disease really requires an all hands on deck commitment. One of the things that we're looking at Us Against Alzheimer's is, are we utilizing all of our federal funding that's committed to providing healthcare resources in communities? And one of the areas that we're going to be looking at is federally qualified health centers that serve over 20 million adults, most of which are uninsured or underinsured or publicly insured. We know that their largest area of growth is the older population, yet they don't collect information about Alzheimer's disease or diagnosis or anything of that nature. We know that there's some that are doing wonderful work. We don't know a lot about other people. And so we would love to partner with members of Congress to begin to have this conversation about how we can extend the wonderful resources and experience that we've had through the federally qualified health centers that are managed by HRSA. It's really important as we pull together these health systems that we remove silos and allow all the different sectors, especially those that are supported by federal tax dollars, that they're communicating and sharing their learnings. And so that's something that our center and at Us Against Alzheimer's, we're going to really focus on. And again, we'd love to work with you. I think we'll have in the chat our email or my direct email. Please reach out to me if you're interested in having additional conversations about this. So with that, we appreciate everyone who has joined this conversation. It will be recorded, and for those who would like to revisit it, or people who weren't able to attend, we're very happy to make that available. Again, I want to thank all of our wonderful panelists, our front end and back end people who've worked on this work, everyone who has joined us today. Let's continue to make this a top priority because we've got millions of people who are counting on us to do the right thing. Thank you.
Thank you all.